Well, LAG-3 stands for lymphocyte activating gene 3. And it's really a promising immune checkpoint to target as it helps to suppress T cell activation and cytokine secretion. And it really has a role in ensuring a state of immune homeostasis. So LAG-3 on its own is a surface molecule, and it binds to MHC class 2, which is expressed on antigen-presenting cells, and it hinders the T cell receptor signaling. It's also expressed on cell membranes of tumor-infiltrating lymphocytes, activated CD4 and CD8 cells, Tregs, NK cells, B cells, and dendritic cells. So it's really got a broad spectrum of activity across our immune microenvironment. So really, it just helps inhibit various types of lymphocytes, and it has shown some synergy with PD-1 to inhibit immune responses. So that's why we thought this would be an interesting target to compare in this neoadjuvant study. FDA approval, which is in melanoma, which was the Relativity 047 trial, which showed an improvement in efficacy of nivolumab plus relatlimab compared to nivolumab alone. So our study was then really designed probably before that study even came out, but we were looking to see if LAG-3 inhibition would be as efficacious in esophageal gastric cancers. And LAG-3 is expressed at a very high level in both gastric, esophageal, and GE junction cancers. So it really made a lot of sense to combine nivolumab and relatlimab in this particular study. We look to determine the safety, the feasibility, and the efficacy of combining a PD-1 inhibitor and a LAG-3 inhibitor, as we said, nivolumab plus relatlimab. So dual immune checkpoint inhibition. But the real novel thing there was it was combined with chemoradiation in a neoadjuvant setting, which to my mind hadn't really been done before. And we never really understand the implications of the radiation. Most studies in the neoadjuvant setting have been with immune checkpoint inhibitors and chemotherapy. So that was one of the novel factors. And then we also looked to measure circulating biomarkers to determine clinical response. And really, we were looking at ctDNA, which I know we're going to talk about in a minute. The design of the study was that it was done in 3 sites across the United States. We did here in Baylor University Medical Center in Dallas, at Johns Hopkins in Baltimore, and the Allegheny Health Network in Pittsburgh. And as I said, we looked to see if we showed synergistic activity for the dual ICI inhibitor plus chemoradiation in patients with operable stage 2 or 3 esophageal or GE junction cancers. The primary endpoint was safety. The secondary endpoint was feasibility, but then we also measured efficacy endpoints of pathologic complete response, major pathologic response, relapse-free survival, and overall survival. And then there was a series of correlative studies, which we'll talk about. The study was essentially divided up into 2 arms. Arm A was nivolumab alone plus chemoradiation. We had 2 cycles of nivolumab as part of an induction where we had a preoperative biopsy, then 2 cycles of nivolumab, then another biopsy through an EGD, then chemoradiation, which is over 5 weeks, with another 3 cycles of nivolumab. So in total, 5 cycles of nivolumab, 2 on their own, 3 interspersed with chemoradiation prior to surgical resection. That was Arm A. Arm B was exact replica, except instead of nivolumab on its own, nivolumab plus relatlimab, the LAG-3 inhibitor, for 2 cycles as induction, and then 3 additional cycles with chemoradiation. So that's the design of the study. We also looked then to see if we could measure circulating tumor DNA to see if we could measure if we were able to decrease the amount of ctDNA longitudinally. Well, so we measured ctDNA at a number of time points. We measured at a baseline before we instigated the immune checkpoint inhibitors as an induction. We then measured it after one cycle of immune checkpoint inhibitors, that would be day 14. After 2 cycles, so that was day 28. And then we had a preoperative specimen, a preoperative ctDNA assessment, which would be post-chemo radiation, so the pre-op specimen. And then we had a post-op, which is MRD assessment, a number of weeks after the surgery was completed. So what we were able to show was that, in addition to that, in addition to measuring the ctDNA, we were also measuring neoantigen-specific T-cell responses. And so what we were able to show there was, as the ctDNA decreases, you almost get a mirror expansion of T cells increasing. So as the tumor burden regresses, you're getting an increase in the immune cells, which is exactly what you would like to see. So in patients, in terms of some of the results, we were able to show, for example, that ctDNA status as early as after the first cycle of immune checkpoint inhibitors, or the first 2 cycles of immune checkpoint inhibitors, may be actually critical in enriching those patients most likely to benefit from immune checkpoint inhibitors in the neoadjuvant setting. We saw some patients where their ctDNA decreased to undetectable after only 1 dose of nivolumab on its own. And that patient, or some of those patients, their ctDNA never went back up. They subsequently had a pathologic complete response at the time of surgical resection, and then for many years after, they've never recurred. So one could ask, are we over-treating some patients if we're seeing such an exciting result as that? Or in fact, if we never see ctDNA decrease, those patients were doing poorly. So this type of information could be helpful to make treatment escalation or treatment de-escalation decisions. Right now, we've been treating everyone almost as a one-size-fits-all, but this data with ctDNA longitudinal assessment, identifying patients who are responding versus non-responding, may help us make treatment decisions as we move along, rather than just not understanding if we're affecting the tumor until post-surgical resection. We were able to show, and people have shown this as well, that there's a couple of different classifications of those. There's patients who never shed ctDNA into the blood, and that made up about 20 to 30% of our patients in this study. So they actually do better than the shedders, those that do shed ctDNA into the bloodstream. But then those that do shed ctDNA, and we're able to measure that and detect it, those that clear rapidly do well. Those that clear at a more prolonged level or durable level, but clear before the preoperative time point, they also do well. It's those that don't clear at all pre-op, or in fact, who increase ctDNA levels preoperatively, and certainly this was in esophageal and GE junction cancer, their outcomes in terms of relapse-free survival was much shorter. And then finally, if you look at those post-operative specimens, those patients that had minimal residual disease, positive disease, they had a much worse outcome in terms of their relapse-free survival. In terms of the median relapse-free survival in those that were MRD negative was not reached in our paper, where it was only 7.8 months recurrence time point for those that were MRD positive. So that would be, that's been seen in other disease settings now, where we know MRD positive patients are really high risk for recurrence. The other thing that's interesting is, what about those that don't achieve pathologic complete response? What we showed here was, when ctDNA was assessed in those that don't attain a PAT-CR, we were able to show those with undetectable ctDNA post-immune checkpoint inhibitors had a much longer relapse-free survival, indicating that PAT-CR may not be the best surrogate biomarker in esophageal and GE junction cancers. I think we're beginning to see that in the large studies. But if we add ctDNA, we may get a more nuanced understanding about how that patient's going to do. So the real-world implications, I think, PD-1 and LAG-3 inhibitors, as you said, they're FDA approved in melanoma. There's a lot of studies now ongoing in other tumor types. In our particular manuscript here, we show that there was an improved MPR, major pathologic response, an improved pathologic complete response, and then longer 2-year overall survival rates compared to historical data, say, for example, with the cross regimen. So I think further studies should be looked at as to the exact sequencing of these particular drugs, because there was more toxicity in the relatlimab arm combined with the radiation. We had some patients with pericarditis and adrenal insufficiency. So I think we just need to understand how we can combine these drugs with chemoradiation in a neoadjuvant setting. But I'm really excited about where the ctDNA and the MRD work can go. I think we're seeing this will have real implications for not just esophagogastric cancers, but multiple solid tumors, where I'm hoping now this will give us a window into the tumor burden regression, and we're able to measure patients that are responding and those that are not responding, and we may be able to change our treatment strategies accordingly. I think that'll be new information that we've not had before. I think the real thing is the circulating tumor DNA. You know, there's a lot of studies with immune checkpoint inhibitors and different disease settings. We now, of course, in the future, will have the antibody drug conjugates. But the real exciting thing is the ability to identify patients that are responding to your treatments, because we've never really had that before. You know, in the older days, we've been giving chemotherapy or chemoradiation, and then we've relied on the pathologic surgical report to tell us how well we did. And then we make our treatment decisions for the adjuvant setting based on that pathology report. But I think what we're showing in this paper that was published in Nature Medicine a few weeks ago has shown, certainly in this particular setting, that the ctDNA work can tell us if our treatment's working. And then if we can clear it before surgery, those patients are doing much better. And then in the post-op space, if they're MRD negative, they also have a much better and a longer relapse-free survival, recurrence-free survival. So we can make our decisions about how aggressive we need to be in the adjuvant setting based on some of this work. And then the ability for us, as we showed in our paper, to have a mirror replica as the ctDNA decreases, the circulating T-cell clones targeting neoantigens are increasing. That's really exciting work, and hopefully this becomes a standard of care moving forward when the larger studies read out. And I know they've all been taking plasma, so hopefully they can replicate these findings at a larger level, and this will become a new standard moving forward.